you hear me? Morning. Wow. Will I do that again? Make noise. Morning. Great, fantastic. Hi everybody, you're hugely welcome. I have very little to say, but I suppose I need to say it to set things in motion. That's who I am, for those of you who don't know me. So I'm the guy who's wheeled out to get things going when everybody else does all the work. I'd like to welcome a very broad church of people here, obviously people from the emergency medicine program, from emergency departments, the people at the cold front. But we also have people from other places that receive emergency ambulances, the acute medicine program, from the Rotunda maternity unit, I gather. All very important people. We've representatives of the National Transport Medicine Program, and we have representatives of the Pre-Hospital Emergency Care Council, FEC. So you're all very welcome. The main purpose of this session is to begin the cascade of training of a protocol, which is to ensure that we have proper structured handover of patients in that critical moment where they're coming from the pre-hospital arena to the hospital arena. And we live, I guess this is about a bit of quiet amongst the madding crowd. I'd like to acknowledge Dr. Owen Kelleher, whose talent and skill and insight captured an awful lot of the stuff in this single slide, an awful lot of the issues, which is that we are continuing to try to provide cutting-edge, world-class healthcare in the bricks and mortar that are the hospitals all over the place. And we're also doing it with various paramedical staff who are increasingly trained, increasingly providing interventions, and therefore it is increasingly important that whatever has happened in the pre-hospital arena, whatever information has been gleaned, gets handed over. And really that's what the ambulance handover protocol is about. I'm really, as I say, just getting this ball rolling, so I'm going to stop now in a moment. Repeat the welcome to you all. I think we're all settled down now. I'm going to hand over to Fiona McDade, who is the lead nurse in the emergency medicine program, just to say a few words about some of the people that have brought this protocol to where it is today, and then we'll be handing over to Leah Walsh, who's the real meat of the discussion. Thanks very much.
Thank you. As with a lot of the products from the emergency medicine program, this is the final step before implementation, and there's been many people involved to get us to this far, because obviously it has to be more than one person's view. So I would like to thank Niamh Collins, Consultant Emergency Medicine in Connolly, Fiona Brady, who's now an aide-on in, oh no she's not, she's Director of Unscheduled Care in Our Lady of Lourdes, Liz Dillon, who was at the time in St James's, Declan Onagan from the Ambulance Service, Martin O'Reilly from Dublin Fire Brigade, who a couple of years ago helped us get all this work together and actually produce the protocol and move it forward to getting it launched. And also FEC, who with Jeff Keys was a leading light in getting this document together and had the vision to bring us all together. And FEC also supplied a lot of the funding going towards the development of the videos that we use. So it's been a bit of a bumpy road on times, but we're glad to be here today. And this is the final step of one stage, but it's also the first step of the next stage, which is implementation, which we'll be going over to you to lead out on from tomorrow. So I'll hand you over now to Leah Walsh, who's coordinating the project.
So by the end of this session, I really hope that you'll actually understand the need for a standardised handover protocol, that you'll be able to improve the interdisciplinary team dynamics through communication, that you'll have a better understanding of the patient care report forms, that you'll be able to improve the measurement of quantitative data that's required for the key performance indicators as set out by the protocol, that you will introduce the I-MIST or AMBO to your department, but most of all that you'll actually implement I-MIST-AMBO within your department. So as we've said already, the protocol that we're going to bring to you today has been a joint collaboration between a lot of teams. So we've had the National Ambulance Service, the Pre-Hospital Emergency Care Council, the National Emergency Medicine Programme, the Health Service Executive and Dublin Fire Brigade. And what we've done is we've actually sat back and looked at what we need within our country, and we recognise that we do need a standardised handover protocol. And we have looked to New South Wales. So in New South Wales was researchers who actually looked at the training and looked at the handovers that they currently had in place. They looked at 2 particular trauma units, and they looked at 373 staff and a total of 167 handovers. And what they did is they actually videoed the handovers and brought it back to the staff members and asked the staff members to review the videos and then reflect on what they actually saw. So the observations that they actually noticed was there an increased length of time for handover that was completely unnecessary. A lot of that was down to repetition of information. So how many of us here have taken a handover from an ambulance crew and then turned around and said to them, what was it you said to me? Did you give that paracetamol? Was he a head injury? Did he have LOC? And then somebody else would come along 2 seconds later and ask the same question again. When this happens, there tends to be a loss of information because we're not picking up the full handover. We're concentrating on things that we need to just maybe relax a little bit more on and actually focus in on the handover for the 90 seconds that it takes. The other thing that the crew noticed was there was a difficulty in actually identifying the clear roles within the ED. So again, how many of us have actually maybe transferred a patient to another department or maybe been there yourself? And unless there's a crew of ambulances lined up, you don't actually know where the ambulance handover area is. Or, on top of that, you actually haven't a clue who the ambulance triage nurse is. Or you walk into a resus and you actually look to see who the team lead is because there's 3 people shouting orders at you and you don't know who it is that you're handing over to. So, while all this is really, really important, we still kind of had missed, I suppose, the key factor, and that's patient safety. So logistics is absolutely fantastic, but unless it's going to improve patient safety, do we need to really be bothered with it? In June 2016, there was another report released which looked at the effect of patient safety as a result of poor handover. So what they noticed was there was decreased patient safety as a result of inadequate handovers. This often led then to the misdiagnosis or delayed diagnosis of patients. So again, when we talk about taking that handover and actually saying, God, did the patient actually lose consciousness? I can't remember. Or does anyone actually remember what that patient took as the overdose? I can't remember exactly what they said to me, or the quantity or the dose. So was that patient a serious overdose, or are they okay? Or did they tell me the patient had chest pain that was resolved with GTN, or did they even give GTN? Okay. The other thing they noticed was there was a high incidence of medication errors. I'm sure there's not one person in this room who will not admit to going to the patient who they've just triaged and the patient has asked for analgesia. And the first thing you think of is, great, I'll get them written up for paracetamol. But then you have to actually go and check the PCR to see whether or not the patient was given paracetamol pre-hospital. I'm sure that has happened to most of us here. The other thing they noticed was there was quite a large omission of care. So when we actually are looking after these patients, we get the handover, and that's absolutely fantastic. But if we're not listening to that handover correctly and we're not taking in that information properly, there tends to be an omission of care. So if you think back again to your own departments, and if you look at the notes that you get, has anyone actually read the patient care report form and then read a nursing note and then read a medical note? No? It's something that I will ask you to go back to your department and do just as I-MIST-AMBO comes in. Because if you actually look at your PCR and if you look at your nursing notes and if you look at your medical notes, read the 3 of them and see what's wrong with the patient, because you're going to get 3 completely different answers. One of them will tell you that the patient was a minor head injury with no LOC. The nursing note will probably tell you that the patient had LOC, vomit by 3, and C-spine was not indicated. And the doctor's note will tell you that the patient had no facial injury. Okay, so what's wrong with the patient? Does the patient need a CT scan? What is the handover? And then the patient or the family could tell me something completely different. We know that this is happening, but we haven't changed our practice. But it's when we look at the figures and we realise that actually 20% of the malpractice cases in the USA in 2006 were directly related to inadequate handovers. That's quite a significant number for something that's so minor and so easy to change. So what we're going to do is we're actually going to ask 2 girls to come forward, and I'm going to do a quick role play. So you see the very first sheet that you have, which says nurse and paramedic. Okay, so that's the role play that we're going to do first. So I'm going to ask the 3 girls to come up. So, as part of the role play, I'll just let you know that the girls that I have in front of me have been absolutely excellent in engaging with the training for I-MIST-AMBO and haven't done any of it. So what we want to actually look at is we want to look at what happens during the triage process in Ireland at present. The girls have been given their roles, okay? So Grace, who's the first person here, is going to be our nurse. She has only been given the nurse sheet. She hasn't seen the paramedic sheet. And Aoife, who's our paramedic for today, has only seen the paramedic sheet. She has no idea what's going on in the nurse's head. Amy is going to be our patient. So I'm just going to ask the 2 girls to go through a very quick triage of this patient.
Hi, Miss Harriet. This is a 22-year-old female. She's a headache and she's vomiting. She has been drinking alcohol all weekend. She didn't want to go to GP because she said, oh, I didn't do anything. And really, she just picked up my foot.
Perfect. So, how are you feeling now? Okay, do you have a headache? Okay, when did that start? Okay, perfect. I'll just do your blood pressure and then we'll get you out to the waiting area, okay? Perfect.
Okay, excellent. So everybody has a pad in front of them. What I want you to do is I want you to look at your I-MIST-AMBO, and based on the handover that you've just seen, actually fill out as much information as you can for me. Girls, that's excellent. Thanks very much. This one? Yeah. Grace, will you do me a favour? Will you fill out your I-MIST-AMBO based on the information that you forgave you? Okay. Perfect. Right. So if we actually look at what should have occurred, we should have seen a clinical handover, because at the end of the day, a handover has occurred. Whether or not it's the way we want it to occur, it still has been a handover. The Pre-Hospital Emergency Care Council in 2013 defined a clinical handover as the transfer of information from one healthcare provider to another when a patient has either a change of location of care and or when the care of or responsibility for that patient shifts from one provider to another. So what we can see from clinical handover is it requires communication, okay? And we've all done communication theory. We're all sick of communication theory, but we still don't practice it very well, do we? No. Okay. So communication has been defined then as an interpersonal activity which involves the transmission of messages by a source to a receiver for the purpose of influencing the receiver's behaviour. So if we break that down, we can see that we have 2 components for communication, and that is that we have the messenger and we have the receiver. So the messenger is our paramedic, and what the paramedic is trying to do is the paramedic is trying to get a verbal and a non-verbal message across. As a receiver, or the nurse or the medic, what we need to be able to do is we need to be able to decode that information through open and active listening. Does anyone actually remember what are the key components for communication? Listening? Yeah. Eye contact. Okay. So we have three main components. So we have the spoken word, we have the voice or the tone, and we also have the body language. So the spoken word makes up 7% of the communication, which is absolutely minimal. So if we're looking at that, that means that 93% of the conversation is potentially lost if we don't hand over properly. We need to be able to make sure that we're engaging in active listening, which means that we need to be able to see the paramedic's facial expression. We need to be able to see eye movements and make direct eye contact with the paramedic. We need to be able to see the body movement and the paramedic's gestures. So if we look at the role play, is that a typical handover that we see? Yeah. The first focus we have for our stable patient is, oh great, you're a paramedic, that's lovely, but my job is the patient. My job is to get the observations done. My job is to triage this patient because I have another 3 waiting, plus the other 5 that's waiting in the triage room. Yeah? We become so task orientated that we actually forget what it is we're trying to do. So during that handover, did Grace actually get to see Aoife's facial expression? No, she didn't look at her once. I know a lot of you probably couldn't see Aoife's facial expression, but from what I could see, Aoife was absolutely disgusted, okay? You all have the scenario in front of you, but what Grace doesn't realise is this was Aoife's 7th long day in a row. Aoife was meant to be going out for dinner with her partner tonight. She hasn't had a break, and now she's not going to get out on time. And on top of that, a patient who she feels didn't require an emergency department has just puked all over, will not sit in a chair and refuses to get off the trolley. Was any of that message actually passed over to the ambulance nurse? No. Okay, so in order for us to communicate properly, we need to step back and look at what it is that we're actually trying to do. So what we're going to ask you to do from now on is going to ask you to just do something very simple. Look, but don't touch. So instead of calling it a handover, we're going to call it a hands off, eyes on. So from now on, when you think of handover, it's a hands off, eyes on approach. And that's going to be for both the stable and the unstable patient, and we're going to show you how. So I-MIST-AMBO is a very simple mnemonic. Unfortunately, in the healthcare system, we are so used to mnemonics. We have ISBAR. How did we learn about ISBAR? Somebody came into the department one day and said, this is your new handover tool, thanks very much, please start using it. True? Yeah. Methane. We've all heard about methane message. Many of us actually sat down and went, oh, do you know what? I'm going to go home, I'm going to study the methane message, I'm going to know it off by heart. Or how many of us said, yeah, when we get a major emergency, I'll pull out the card, it'll be fine. Okay? Again, it's a mnemonic. Very, very simple to implement, we just need to follow the steps. A, B, C, D, E is another very simple mnemonic that we have. And another one that I want to introduce you today is to one called ASHICE. But the most important is going to be the I-MIST-AMBO. So I-MIST-AMBO is very, very simple. It was introduced by an intensive care paramedic in New South Wales who recognised that there was a need for a standardised handover tool. And it was Jacinta, I can't remember her surname, but this girl is the one who has actually sat down and looked at what information we need. And she came up with I-MIST-AMBO. And it was then New South Wales that researched it and actually implemented it nationally. It's very, very simple. It's broken up into 2 components. So the first component then is it is the National Ambulance Handover Protocol that we're going to start bringing in here in Ireland. Okay. As we said, it's the hands-off, the eyes-on approach. It's a very, very simple tool. And if we look from a length of time perspective, it actually only takes 90 seconds. It's very quick, very effective. And it's split into the 2 components. So I-MIST is the first component. So we're going to ask the paramedic to identify the patient. The paramedic will then tell us what is the mechanism of injury or what is the medical complaint that the patient has. They're then going to tell us the injury or the information related to the complaint. They'll hand over the patient's vital signs and let us know whether or not this is a stable patient, and then the treatment and the trends that this patient has received. At this stage, I'm going to ask you to do something that's very, very strange, and that is do not interrupt, do not ask a question, just let them hand over. And then they will pause and give you a chance to ask questions on the information that you've just received. Is that all right? It's very simple. After they've paused for the questions, the next part then is the AMBO. So that they will then tell you the patient's allergies, their medication, the background and other information. So the likes of your social history, or the likes of this patient has refused to travel because she didn't want to go to the GP and she doesn't like her boyfriend. The likes of the fact that the patient is completely stable and I feel that this patient is appropriate for the waiting room. Things like that, okay? And again, then there's another pause for additional questions. So as we said, it's hands off, eyes on, don't interrupt. Is there any questions on it so far? Okay, so then we're going to get into the receiving of the handover of the stable patient. So when we're looking at the handover of the stable patient, we're going to ask each area to make sure that they have a clearly signposted handover area. Okay. How many of us currently hand over on a corridor that has patients, admitted patients on trolleys? Yeah. How many of us would like our family member to be handed over in that particular area? No. It's not confidential. It's not fair to the patient. We don't know what that patient is coming in with. We don't know their background. So we need to identify an area that is confidential. I know that in EDs at the moment, we're absolutely jam-packed and we do have admitted patients everywhere that we can, but it's up to us to protect our patients' confidentiality. That's what we're here for. Okay, so we need to really look at our departments and really identify an area that we can make sure that there is not going to be other ambulances or other admitted patients. The other thing that we really need to look at is how do we identify our ambulance triage nurse clearly. So have any of you actually watched any of the, whether it be the hour-long or the 15-minute videos? One person? 2, 3? Okay, great. So 2%. Excellent. What that actually says is it talks about how or methods to actually identify your ambulance triage nurse, and they talk about a coloured lanyard, or they talk about a lovely little armband, okay? Or the other thing they talk about is having a whiteboard and actually writing the ambulance triage nurse's name. What we're going to say to you is there is no national policy or protocol for actually identifying your ambulance triage nurse. That's completely up to each department as to how you do it. But you need to be aware that not every ambulance crew knows your staff. I work in an emergency department where I tend to know the crews quite well, okay? I tend to actually walk by the ambulance crews and put my head down and say, sorry lads, I'm not it today. But they don't know who is it. I can write up the name on the board and that's great. The crews more than likely will know who the staff member is. But what about the crew that has to come from another area that has never actually met these nurses before? So we just need to be aware of these kind of problems. The other thing that we really need to make sure that we implement is infection control precautions. So again, a lot of us have tried to find an area for ambulance handovers. And we've tried to find an area that's confidential. But we're forgetting the part about infection control. We're forgetting that we actually need PPE. So we need our gloves, we need our aprons, we need our sick bags available. How many of us actually have them available at your ambulance reception area at present? A few, okay. We're really bad in the department that I work in that I will point you to the nearest cubicle, or I'll try and run for a sick bag in the hope I get it in time, but we have nothing set up. So that's something that we need to review. The other thing that we would like to see is a sink for hand washing. Now, that is absolutely almost impossible, okay? If you are lucky enough to come from an area that can get a sink, that's excellent. But even if you have hand gel and you can actually say to your crew members, the next sink is just here if you want to wash your hands there. Or when you actually hand the patient over and, you know, put them onto the trolley, they can use the sink in that cubicle. That's absolutely fine. The final thing that you need to consider is if we're going to start getting involved with PCRs and we're going to actually start looking at our key performance indicators, and that's something I'm going to talk about now in a minute, we also need to have somewhere that we can actually do the documentation and the triage. So we're asking us to try and document and to triage as close to the time as possible. So if you can find a workstation or even a mobile workstation that you can actually bring to the patient, that would be an excellent idea. So when you receive your stable patient, we're going to do the hands-on, eyes-off approach. and we're going to ask you to pause for the questions between I-MIST and AMBO. As I said, the additional information is given at the end of AMBO if required. And this is also the point that we can ask family members for their input into the handover, because family members can often provide information that, the crew may not know about. The patient is then going to be moved into the ED care area. Okay, so when the patient is moved from the ambulance trolley or the ambulance chair onto the ED chair or the ED trolley or the ED waiting room, this is the point that handover has officially occurred at. Okay, so this is the point that you're going to document. You're not documenting the verbal handover, you're documenting the physical handover time. So this is where I'm going to ask you to start completing the PCRs. So everybody should have 2 forms in front of them. I know there wasn't enough to go around, and I know that there's some packs that only have 1 PCR. So even if you can have a look at the person sitting beside you. Okay. Perfect. So is there anyone who hasn't had a PCR that would like one? I think I stopped shaking. There's a fine balance between water and getting sick. Yeah. I'm calming down. That's the point. I'm calming down. Okay, so at present in Ireland, we have 2 different types of patient care report forms. We have the one that has this symbol on the top, which is the Pre-Hospital Emergency Care Council, and that's the form that's predominantly used by the Dublin Fire Brigade at the moment. There's a lot of information on these forms, and it's absolutely great if you want to look through them and you want to make yourself aware. But there's 2 points that I want you to really know about, and that is the handover time and the receiving staff signature. So, has everybody got the PCR with FEC on it? Yeah. Can everyone see the handover time? Yeah? Okay. Yeah, it's too different. Okay, so that's where I want you to agree a handover time with the ambulance crew. And as I said, it's the time of physical handover, not verbal handover. So when we start looking at our KPIs, or key performance indicators, what we're hoping to achieve is 95% of all ambulance handovers in Ireland will happen within 20 minutes. So 95% of our ambulances that do arrive into ED will be physically handed over in EDs within 20 minutes. Okay? There are reasons for delays, and we're going to get into that in a wee while, but we just need to try and look at how we can record them. The other patient care report form that's in existence at the moment is the one that's used by the National Ambulance Service, or the HSE. Some people again have this one in front of them, and I'll ask you to just kind of show them around, okay? It's very similar to the Pre-Hospital Emergency Care Council one. Similar layout, but the boxes are a little bit closer together. Again, the at handover is in the very first section. And again, this is where you must agree the time with the ambulance crew. What I will say to you is this document is belonging to whether it be the National Ambulance Service or the Pre-Hospital Emergency Care Council, and it's their document to complete. So it is actually going to be the paramedic who writes in the time, but they must agree that time with us, okay? What we need to actually look at then is we need to look at the IT systems and make sure that they actually have the ability to record the arrival at destination time and the handover time. Because these are the 2 points that are very, very critical if we want to be able to monitor our KPIs and see what we are actually achieving nationally. It provides that quantitative data, and it helps us then to audit our KPIs and see what it is that we can change. So clerical, this is why I've asked for you to come today, because this is the part that I really need you to get involved in. I know that there's various systems that are in use in Ireland at the moment, and one of them is IPMS or I-PIMS. So on the I-PIMS, for the clerical staff that are here today, you'll notice that you have 2 different boxes. So on your attendance details, you have the arrived at time. Can everyone see that? And that's the time that the ambulance has physically arrived in your department. The next screen that I'm going to show you is this screen here, okay? So when you get in under SDU and KPI, you'll see ambulance arrival time. What we can do if we want to do it from a national point of view is we can actually change this box to actually say ambulance handover time instead of ambulance arrival time. And we can document then the time that handover has occurred at. And that will give us our 2 points. That's something we need to look at nationally, and we can discuss that outside of here today. So that's our I-PIMS. The other programme that I have here for you today is Symphony. So Symphony is quite good. So the 2 boxes are actually side by side. So we have the ambulance arrival time and the ambulance handover time side by side. Now, I think there's not all Symphony actually have this, but again, we can talk about that later on and see how you can go about getting it onto your systems. I know there's other systems out there that I haven't shown today. So what you need to do is you need to talk to your IT department and see, is there a way that you can actually record your arrival and your handover time, because that's going to be one of the key parts for us to be able to monitor this quantitative data. So when you're actually completing a patient care report form, you need to be able to sign to say who it is that has actually received the patient. So can everyone see the red arrow? Yeah. So that's where I'm going to ask you to sign. So if you have a look at your PCRs or your patient care report forms, it's normally at the very back and in the very last section. Oh, very big. Oh, there it is. Yeah, the EPCR is coming out. Don't worry, it's changing again. It's changing again. Okay, so can everyone see the point that you need to be able to sign? Yeah? So it's very, very important that you do actually sign to say that you've received the patient. I'm not sure if there's many departments that function similar to the way ours does, in that we have a great friendship, I suppose, with our ambulance crews. And what our ambulance crews might do is they may actually hand in the PCR to our reception and clerical staff and then come and hand over the patient so that the patient is registered. But that means that the handover time won't be clearly documented and the staff more than likely don't sign the PCRs. Okay, so that's something we need to be aware of and look at a local level. So from the PCR point of view, there's also a section that says additional information. And remember when we were talking about the fact that there may be a delay in clinical handover and we may breach our 20-minute KPI, and that's absolutely fine. The ambulance crew can actually document in this particular area as to why that's happened. And the 2 main reasons for that is ongoing clinical care, which is more than likely going to be our unstable patient, and we'll talk about that in a moment, or a delay in verbal handover. So if there is a delay in verbal handover, we need to escalate that throughout the department to make sure that we are meeting our KPIs. And as I've said again, it must be signed by the receiving staff. Has anyone any questions on, yeah?
The 20-minute, that's up until the point of verbal handover.
Physical handover.
Physical handover.
Physical handover, yes.
That's when we take responsibility from the crew.
Yeah, well, we can have joint care during that time.
Yeah.
So our ambulance crews at the moment are extremely qualified. The lads are able to give analgesia and they're able to give antiemetics and things like that. So there is an element of joint care while that patient is in the department waiting to be physically handed over. But the handover time that we need to record is the physical handover, not the verbal.
The KPI is 20 minutes for that.
20 minutes, yeah.
And so you have a verbal handover, and the patient still remains under the care of the crew until there's a physical handover.
Yeah, well, joint care.
Yeah.
Yeah, yeah. Absolutely.
Can I just ask?
Yeah.
So you get a verbal handover and there's no trolley to put the patient on.
Okay.
You call from Dublin to say that the tube ambulance in the department. So
We
you
need-
can't take a handover of that patient.
Well, you are taking a verbal handover,
Yeah.
but as I said, the physical handover has yet to occur. If there is a delay in ambulance handover, you need to escalate that through your hospital.
Yeah, you've done all that.
You've done all that. Well, it's up to your hospital at a local level to be able to resolve that issue, okay? So we need to really try and keep on top of our KPIs. I know A&Es are really, really tight, and I know handover times are difficult. But as the staff that are working on the ground, it's up to us to try and implement it, and it's up to us to try and escalate it up through and make them listen.
Like you've escalated it up, there's
Yeah.
still no trolleys, which happens regularly. And the ambulances, ambulances are coming through the doors, you have 5 to 6 waiting at a time. The first ambulances arrive an hour and a half ago, and you're ringing, escalated up. There's ANU still open, so they can't give you trolleys. SAU still open, they can't give you trolleys. What happens?
Well, that's going to be up to a local level as to how they're going to resolve that.
Okay.
You know.
And still,
You're doing a great job.
and
They-
you still have Dublin ringing you every 20 minutes telling you, are you aware?
Yes, yeah.
Can I just
Yeah.
talk for a second, because this is an area of huge contention. I think I saw another hand up there a moment ago that I'd be happy to take. Mr. Plunkett, Professor Plunkett, sorry, do you want to speak?
I think we've got to remember that the person who really matters is the patient. And the fact that there isn't a stretcher or trolley to put them on this particular patient, maybe there's another stretcher or trolley somewhere else that the patient on does not actually need to be on a stretcher or a trolley. That is local management, and that is what one must do. It's not always possible, but the vast majority of the time it is possible.
Thank you very much. I think that's the essence of this. Is we want to separate the operational hassle and tedium, and we all know we're completely bet down. But the single most important patient always is the patient that's right in front of you at this moment in time. The pressures in the system at the moment to move towards what I call a drive-by handover, where you just fling the patient there and get the vehicle back on the road, is huge. And that's what this little nugget is in the middle of, to make sure that it is a quality handover for you, the patient, the relative, and all those people. Thanks.
Thank you. Yeah.
I know we have the KPIs for the ambulances to hand over, but we also have our Manchester triage KPIs. So when you have patients in the waiting room that have self-presented that you haven't, nobody has assessed, and there's delays of up to an hour to triage them when the ambulance comes in, how are we prioritising these, or how are we supposed to, because that patient has no qualified personnel after seeing them or assessing them, they could be more unwell.
Can I just keep us focused on the tool that's here today? This is frustration that once we're finished, because I know Leah's put a huge amount into the preparation of today, we can go on about all that stuff at the end, because they are two separate issues. Whether we are properly resourced and staffed, and the numbers of patients coming through, and the importance of high quality care for each patient that we can deliver. And they are competing tensions, there's no doubt about that. Here's trouble. I see Rob Egan with his hand up.
It's a very practical question about the
Okay,
form
thank
itself. Let's say where our department, they come in and there's a triage point for them, and the verbal handover can be done there. So presumably based on this will get signed at that point. But obviously in many departments there may not be able to do the physical handover because of the locked trolley. Does that mean there'll be basically someone else then will have to come and sign the other part of the form?
I think
when the physical is done?
what we would like to do is get this tool embedded in practice. There is no doubt there will be growing pains, there will be this doesn't work for this reason, and there'll be tweaks later along the line, but it's just the simplicity of this tool is what we're trying to deliver. So I'm really happy to come back and have a chat about these things at the end, but I've interrupted Leah's timing twice already today, so if we can just go back to this and then we can take that stuff at the end of the session. Is that okay?
Perfect. So just again to highlight, this is the area that we're asking you to sign, and this is the Pre-Hospital Emergency Care Council PCR. The National Ambulance Service PCR is slightly different. So if you look at section 2 of 3 on your National Ambulance Service section, it should be the very bottom line of section 2 of 3. And this is the section that we're asking you to sign on the National Ambulance Service Patient Care Report form. Is that all right? Okay, so we've gone through the handover of the stable patient. So now what we want to do is we want to look at the actual handover of the unstable patient. And we're going to talk about a thing called a pre-alert. So when everyone's leaving today, each department is going to be given a pack to take back as trainers, so you can actually make sure that this tool is implemented. And in that pack, you're going to find your protocol. The protocol talks about a pre-alert. So at the moment, a pre-alert is done by any of the ambulance crews that feel that there is a need to alert the department that this patient is coming in. They then give that message to the control room, who pass it on to you in the form of ASHICE. So ASHICE is something I talked about earlier on, and this is what it actually stands for. So it's on the back, you know your notepad? It's on the back of your first sheet. So an ASHICE message is a very, very concise message that literally just gives you the age, the sex of the patient, the history, the injury or the illness that we're expecting this patient to present with, their condition, so sometimes we may get their vital signs, and then the estimated time of arrival. The other thing that you'll notice is there's 3 different sections. So we have life-threatening, resus required, serious non-life-threatening, so rapid assessment needed, or non-serious non-life-threatening. So they may actually be able to tell you like that this patient requires resus, and that will also be ticked on the PCR or the patient care report form by the ambulance crew. Has anyone any questions on your ASHICE message? Yeah.
Sorry, sometimes the message doesn't come through correctly from what the EMTs will tell
Yes, yeah.
and then it comes through like a GCS is often wrong.
Yes. Okay. If you find that that's happening, that's something that you can bring back to operations service of the ambulance crew, and then they can actually solve that.
Yeah.
Is that okay? Perfect.
It's happening regularly.
Okay, well, if you continue maybe to bring it back and feed back to them, they should be able to go on and do additional training from a pre-hospital point of view. Okay? So when you're receiving handover then of the unstable patient, you organise resus the exact same way as you do for any other patient. The only difference is this time we're actually going to start allocating roles a little bit differently than we would have done previously. Like the ambulance triage nurse, it is so important to actually clearly identify your team lead, okay? And as we said earlier, like it has often happened in resus where 3 people think that they're the clinical team lead, and 3 people are answering, and 3 people are given instructions. So you need to come up with some sort of visual method. You can have like your aprons, your lanyards, whatever it is. You're going to allocate roles, and I'm going to get into that now in a few minutes. And you're going to request assistance from clerical staff. So again, clerical, this is something that's going to change in the way that you register your patients, and it'd be absolutely excellent if we can get you on board with this, because it's really going to change how we register our patients and how we monitor our KPIs. So again, with the unstable patient, we're going to ask for a hands-off, eyes-on approach where appropriate. So that means if you have a patient who is in cardiac arrest, we're not going to ask everybody to bring the patient in and everyone step away and stop doing CPR. That's not realistic. What we are going to ask you to do is to continue CPR with the people that are necessary, okay? So continue your compressions, do the life-saving things that are necessary, but you don't need everybody screaming and shouting. You don't need somebody trying to get a line and bloods in right now. They can wait 2 seconds. You receive your I-MIST handover while the patient is on the ambulance stretcher. And the reason for this is to make sure that your clinical lead has an idea of what's going on. We're going to see now in a second that an I-MIST handover takes seconds, literally seconds. Only the team lead and the pre-hospital lead communicate at this stage. So this is why we're asking that when you're in your resus room, I know adrenaline's flying, but I really need you to concentrate on just trying to keep the noise level down and allow the handover process to occur. Once you've done the I-MIST handover, you then move your patient from the ambulance trolley onto the hospital trolley. And it's at this stage then that you can give a full I-MIST-AMBO handover and all care can occur. So as I've already said, this is absolutely excellent. The hands-off, the eyes-on approach is something that we need to adhere to, but it's where it's appropriate. Okay? When we look at then the allocation of the tasks, we're looking at the allocation of clerical tasks. So something that may be new to a lot of departments is actually asking our clerical staff to come into the resus and to actually pre-alert the clerical staff that something is coming in. How many departments currently actually, when they get a pre-alert, tell the clerical staff that there's something coming? A few. That's brilliant to see. I have to say, where I come from, we tend to be quite poor. We don't tell them. And if we do tell them, it's a heads up, but we don't actually ask them to get involved. How many departments, when you're actually handing over the patient, wait until the PCR is complete and then the PCR is given in to get the patient registered? Yeah. Is there a delay in that handover? Yeah? Yeah, I know, like, from personal experience, if we're doing, whether it be a trauma or a cardiac arrest, our pre-hospital staff are absolutely excellent and help us, you know, until we get the patient across and until we kind of stabilise the patient. They'll help us with different tasks. So it could be the 20 or 30 minutes where we talk about that ongoing clinical care, where that PCR still hasn't been filled out. So therefore, there's a delay in actually getting that patient registered and there's a delay in starting the investigations. And that's the reason it's so important to actually get your clerical staff on board from the very beginning. So if you bring your clerical staff into resus and ask them to start taking down the patient details as the I-MIST-AMBO is happening, that registration process occurs a lot earlier and we can actually get the patient logged on the system and we can get the investigation started a lot quicker. The other person we need to look at is the nurse, and we need to look at, is there any way we can utilise the nurse during this? And there absolutely is. So for the EDs that are taking away packs today, we're going to ask you to take away quite large posters that you can put up in your resus room. And the poster is labelled I-MIST-AMBO. So we're going to ask, as the ambulance handover is occurring between the clinical lead and the pre-hospital lead, that we actually get them to fill in the I-MIST-AMBO. And that way everybody can clearly see what the handover is and everybody is getting the information. And not only that, but when the paramedic steps out and your adrenaline is starting to wear down and you're trying to remember what it is exactly they said, it's written down. Okay, so it's very important that we do get a nurse to get involved in the documentation at this stage. Right, what I'm going to do is I'm actually going to do the second role play, which is the last one in your pack. I'm going to ask the two girls to try use I-MIST-AMBO to hand over the next scenario. And I just want to see, is there a difference between the two handovers? So, Grace, because you're completely blind. Yeah, yeah. Okay, so again, similar to the last one, what I'm going to ask everybody else to do is I'm going to ask everybody else to fill in the I-MIST-AMBO and see if there's a difference in the amount of information that we actually receive.
Hi Grace, this is a 30-year-old female. She's 22 weeks gestation and she's kind of PV bleeding and lower abdomen. Her she has a minimal blood loss. Signs and symptoms: blood pressure is 143 over 86, heart rate is 86, respiratory rate is 24, and temp is 39. as far as we haven't given her any treatments. She has no allergies, and she's not on any medication. Background, Patricia is on an IVF treatment, and has been for the last 3 years. And I asked the controller for a resuscitate.
Perfect. Well, Patricia and Aoife, we're going to move up to the cubicle that we've allocated for you here. We're going to do a set of vital signs and we're going to get you across onto the bed. Is that okay? How's your pain at the minute? We'll get you over now.
Perfect. Thanks very much, girls. Okay, so did anyone feel that there was a difference between the two handovers? Yeah? Okay. Was there a difference in the amount of information that was handed over? Okay. As a nurse or a clinical person, would you find that handover more beneficial? Okay. And is it something that's easy to implement? Yeah, absolutely. So, in conclusion, if we have a lack of standardised handover, it's going to inhibit the transfer of information and it's going to directly affect our patient safety. So as we talked about earlier on, 24% of cases in the USA were directly related to poor handovers. If we can improve our interdisciplinary communication, so our non-verbal communication, and observe that hands-off, eyes-on approach, we will actually achieve a much better handover. We need to make sure, though, in doing this, that we accurately record the times that the patient comes in. So ambulance arrival and ambulance handover times, to make sure that we monitor our KPI and try to stay within that 95%. I-MIST-AMBO itself, for the stable patient, we need to make sure that we have clear identification of the ambulance handover area and the ambulance handover staff. And again, that's going to be left to each department to figure out, to look at your own department and see how you can achieve that. We need to make sure that the handover is only complete when the patient is physically handed over. So please, when you're signing the handover time, it's the physical handover time that you're signing. When you have your unstable patient, your I-MIST-AMBO handover is going to have clear identification of the team lead. We're going to have a structured handover. So what we're going to do is we're going to use I-MIST on the ambulance trolley, followed by a full I-MIST-AMBO on the hospital trolley when the patient's transferred over. And I cannot stress how important it is to please ask all clerical to get involved in this process, because it's the clerical staff who are going to input the data into whether it be IPIMS or whether it be Symphony or Maximus or whatever it is that we're using. And if we can get our clerical to attend at the unstable patient, we are going to really improve the times for our patient care. What I'm going to say to you now is that the training is now available. The video is going to be in your pack on a USB along with the protocol. Everybody in this room today is going to become trainers, and I'm going to ask you to now go back to your departments and start implementing this in your departments. The pre-hospital staff have been trained in I-MIST-AMBO, so we can ask them to start getting involved. Is that okay? Okay. Has anybody any questions?
Can I ask you a question?
Yeah.
The systems that you say for clerical people to input the time on this
Yeah.
say we don't, if a hospital doesn't have any of those systems that you were talking about?
We can look at that then later on. That's something we'll talk about outside and see what we can do to help you.
Okay.
Yeah. Yeah.
The verbal handover, there's nowhere for the hospital staff to sign for that, is there?
No, because what we're saying is it's not the verbal handover. It's joint care until physical handover has occurred.
But the verbal handover will be done and then there could be a gap, obviously.
Absolutely, yeah.
Second one.
So that's,
For the crews, obviously they're well aware that although the verbal handovers happen, it's not an immediate sign off.
oh, absolutely. But that's what we're saying. That's something we bring back to a local level. But the handover time that we're recording is the physical handover time. Like, we're not splitting handover into verbal and physical. Handover is physical only, and joint care in between.
And it's as far as the ambulance service is concerned, it's okay to go and take a verbal handover
Yeah.
the actual sign off.
Yeah, and again, if there is a delay in your times, that's something that you need to escalate at a local level.
Sure,
Yeah.
that's our own problem.
Yeah, absolutely, unfortunately. Anyone else? Oh,
Can I just about this tool, I don't want to get it lost in the quagmire of the world in which we live. You know, this is about a common language in the same way as ATLS and ACLS and that have gone before. That we all know what it is we're expecting people to say, and they say it. We receive it in much richer fashion. We're trying to make sure that there is a quality tool in the middle of, like, this is teaching grinding to sub aids. We all take AMIST handovers all day, every day. I've just worked an extremely busy weekend. We had lots of major trauma coming in, where there was a lot of pre-hospital physician input, and there was really exciting things going on. But actually, it's the moment of eventually that patient is handed over, and people are unsure when they're stepping back and when they're stepping in. We're trying to just be clear, this is a quality handover. Now, there's all sorts of other stuff going on around it. There isn't enough space to put people in. So quite separate to this clinical handover tool, there's the operational handover. There's the ambulance turnaround time. So there's KPIs coming out very soon for clinical handover, which is 95% of it should be completed within 20 minutes. And then there's the difficulty of when we can release the ambulance back to the community. Everybody would say you should be able to do it immediately, but you know that you have to care for the welfare of not just that patient that you've successfully handed over, but all the other patients in the department. I've often said to people, I can offload any ambulance, anytime, in minutes. I just open the broom cupboard and put the patient in there. And they go, oh my God, we can't do that, you know. So we're trying to make sure that we get away from the drive-by handover, as I say, which everybody thinks, how hard can it be? Make sure there's a quality tool, and then we deal with all the other stuff in the usual, make it up as we go along.
perfect.
All right. Martin O'Reilly from Dublin Fire Brigade. Just to correct just something that Leah said, although the National Ambulance Handover Protocol has been on the FEC website for practitioners to look at over the last couple of years voluntarily, we will be starting the same rollout as yourselves from tomorrow when we receive the training material at the end of the program. So
Perfect.
confirm that, so we'll be going along the road together.
Brilliant. Thanks, Martin.
Because I actually spoke to a couple of paramedics during the week and asked them, did they know about the I-MIST-AMBO handover, because we used it in A&E for the last while. They hadn't clue what I was talking about.
What area?
It was a little bit scary. Some were not aware of it at all, and some were aware of it but didn't receive the training.
Do you mind me asking what department?
Galway.
Galway. Perfect.
Yeah, now
We'll bring that back.
circulated since I've queried a couple of them. One of them went back, and the link for the video has been circulated to them.
Perfect.
Can I just talk again about the real world at the moment? We all go away in courses, we all learn new skills, we all say, that's brilliant, I can't wait to do it. And then you go into your own department and, it's not possible to do it, so therefore you forget you ever learned it. There has been training in this, but there's also brought that not
Can I just point out that it's a two-way conversation, and if you impose your end of it on the conversation, you will get I-MIST-AMBO. So even if somebody comes in who's never seen it before, if you ask the questions in the appropriate way from them, and I know that sort of brings you to the first break, you will get the information that you require for it, even if they've never been trained in it, as long as they can speak the same language, whether that be Berla or Gaeilge up in Galway, I don't know.
Okay.
Thank you. And I think you've presented in a very clear, credible fashion that we all recognise what's going on. And certainly we wouldn't want a silly unintended consequence that we know that wouldn't happen of, you don't know about I-MIST-AMBO, then I'm not doing handover. Clearly that would be ridiculous. But it is a journey that we've travelled together, and this will eventually go back.
Sorry.
Sorry, when I left the 06 acne was getting going, I advanced since on the Dublin Fire Brigade and National Ambulance Service, and none of them had tried to be understanding. Now, National Ambulance said they'd been trained up 2 years ago.
Yeah. Yeah.
They didn't know this was coming out this week, and they didn't know anything about it either, so that was the same question.
Okay. I suppose it's similar to ourselves in that this has been available since 2013, and in 2013 we asked all sites to watch the hour-long video. Then we asked all sites to be trained by March, and there is a delay. People are busy. There's a lot of things ongoing within departments. But it's only when we really, really push that we're going to actually achieve that. So it's up to us now to drive that. Okay.
This is change management, this is implementation. In the national clinical programs, we go into our ivory tower and say, blank sheet of paper, let's draw the perfect world, wouldn't that be great? Go and do it. And actually embedding it and carrying on business as usual.
So what I will say to you is, if we continue to change nothing is going to change. It's up to us now to be the instigators and to really drive this within our departments. And as and from today, you're it, okay? So you're going to be the people that are going to actually be driving this, and you're going to be the people that are bringing this back to your department and making sure that it's implemented. I'm going to be here to support you up until the end of August. So whether that be by email or by phone, or if you are really stuck and you need me to come out to the sites and actually see, can we work around the logistics, that's absolutely no problem. So the support is there for you up until the end of August. But we really need to make this work for our own patient safety. All right.
I used to be concerned with the introduction of 2 new tools, that the AMBO is still being used and it's still on the PCI form.
For
just the AMBO is still on both PCI.
Oh yeah, AMPL is
Gone,
no, AMPL is the way the paramedics are actually going to take their patient history. Okay.
Should they not be done as AMBO then?
Their handover. So when you look at the protocol itself, the handover says that the paramedics need to actually look at it before they arrive, and they need to construct their I-MIST-AMBO handover prior to arrival. Whereas SAMPLE is their assessment tool, it's not their handover tool. There's a difference between the two.
It could potentially cause, I just think it would be easier to have the energy.
But they are. Oh yeah, no, absolutely, but they should be using I-MIST-AMBO, because as I said, ABCDE is our assessment, but ISBAR is our handover. Do you know, there's a difference between the two. So pre-hospital, AMPL is their assessment and I-MIST-AMBO is their handover tool. So it's just a case of them actually handing over or changing over to I-MIST-AMBO. Okay?
Sorry, just from a clerical point of view, you're looking to have the handover time as the registration time now, is it?
Yeah.
So if, like, a lot of the time we would get to the ambulance before an auto because we can do it on camera, so do we delay registration and wait for a handover time?
No, absolutely. Don't delay registration, because we need to make sure that the patients are registered. But we need to see, is there a way that your particular IT system can record that the time the ambulance arrived in your department and the time that the handover occurred at? So I'm not sure what system you're working off, but I presume at the moment you've only got the one input.
Just the time we register,
Okay.
we'll just record to capture that time.
Well, if you're able to bring that back to your IT and see, is there any way that they could add in another area for you to actually record the two and see, you know, if you can. Great.
No other electronic way of recording that.
Sorry.
The ambulance crew pass the arrival time.
Sorry, say that again?
Is there no other electronic means of recording that?
Of recording.
The arrival times. Was there not supposed to be an idea of a tag, some form, a scan, PDF?
I think there is a few departments that are using the scanner all right. There is a few changes that will be coming down the line with regards to electronic PCRs and things like that. But at the moment, there's nothing national that I'm aware of.
There is a whole load of change happening in this environment in order to meet KPIs, in order to maximise the use of the resource of the ambulance. There is, I mentioned earlier that there's this handover tool within the total turnaround time of the ambulance. So there is a pressure to measure 4 time points. Time 1 is when the ambulance turns off its key, having arrived at the emergency department, and declares themselves arrived. Time 4 is when they then declare themselves available as a resource to be called out again. In between that, there's times 2 and 3, which is where this tool sits. Time 2 is when the ambulance service arrive at wherever it is where handover can begin. And time 3 is wherever it is the handover can end. Now there is a point of shared care there during that time 2 and 3, and that's the way it is. You know, if we delay the patient for 2 hours because of all the other pressures in the department, nobody's saying that's a good idea, nobody's saying that's right, but you do have to take a risk balance assessment of what's going on within your environment. During those 2 hours, if there's an adverse event on the part of the patient, well, it is shared care between those who know the patient intimately and are caring for them, and the emergency department staff who should be able to receive them in their environment.
Can I just give an example of what it's like in the pre-hospital sphere? The Saturday before Christmas of the year before last, bringing us back to
Embedded in your head, obviously.
not even it is, because I was in the city centre on my bicycle, just turned around on the shop window and saw a bicyclist flying through the air from a collision on Bachelor's Walk. And he landed very nastily and he was very sore. So that stopped all the traffic along the North Quays in Dublin for the next 45 minutes because there was no ambulance available in the city centre for 45 minutes because they were all sitting at the emergency departments. Fine, I had a crew of Dublin's finest firefighters with me, but it was a long, long wait. And that's part of what we're trying to avoid in getting the ambulances back out of where they belong. But the other bit about today is, as you quite rightly say, when that guy gets in, somebody has to know he's been lying on the deck for 45 minutes, getting colder all the time.
Absolutely crucial. Yeah, absolutely crucial. Thanks for that. And what I think is really important is that we understand this tool is about the patient that crew and Pat on the street have been caring for, getting that patient through the system as safely as possible without reversing all the excellent pre-hospital care that they've had, and stitching that into the fact that they're in a very crowded environment now, and that's where an escalation policy is important. So this tool is this tool, and then we want to start embedding the fact that ambulances are now delayed into the escalation policies in hospital. Now that's an operational thing. I don't need to sound like Father Jack or being ecumenical or matter or whatever. But you know, we need to be very clear that it is a difficult environment in which we work, but we want to deliver the best care we possibly can.
Sorry, just to add a quick thing. Registration time could be when the family come in and register the patient rather than when they ever have a conversation with the ambulance crew. And it doesn't mean an arrival time.
That's right. Yeah. So separate, there's an awful lot of stuff, and an awful lot of stuff is being funded and designed by people who never set foot in an emergency department. So we need to keep reality there too. So there is software coming funded by the system to allow the ambulance guys to press a screen that says I've arrived at the hospital. Then within the emergency department there'll be another screen that's jointly pressed to say I've arrived at the place where handover can happen. Then there's a third time you can press it that says we now accept an electronic handshake that handover has occurred. And then there's a fourth point when they get back into the ambulance to say we're available. In between time 3 and time 4, sometimes they need to take a break, they need to clean their equipment, they need to do whatever, but you can't affect that within the emergency department. You can certainly affect the time between 2 and 3. They're now our responsibility to receive this handover as fast as possible. The reason I can't do it is because half the staff haven't turned up today. It's a very busy environment, yeah. I need to put pressure on the hospital to say that ambulance turnaround is now delayed.
Okay.
That's what we're trying to do.
Sorry.
Jerry, you might be the best placed to answer this kind of logistical question, but like we're all agreed clinical handover and good communication are what we're at. But we can be kind of having mnemonic overload. Why did you go with I-MIST-AMBO as opposed to ISBAR-AMBO? Because effectively you're communicating the exact same thing.
If you look at the study from 2016, which is, just give me 1 second.
2016 study was,
This one. Okay, so this particular study actually compared ISBAR and I-MIST-AMBO, and they found that they are quite similar. But if you look at what ISBAR provides and what I-MIST-AMBO provides, you actually get a better handover from the I-MIST-AMBO.
well, I-MIST-AMBO was decided well before 2016. So
No, but this particular study compared the two handovers together.
So
Because what they had said was that there was a need for a standardised handover tool, and whether or not ISBAR or I-MIST-AMBO, was preferred. And what they had said was if you actually look at I-MIST-AMBO, it slots into ISBAR, but it actually breaks down the information a lot clearer for handover.
Is that not vested interest?
the answer to the question why I did it is because that's what I inherited, is the honest answer.
yeah, no, I
Yeah.
Can I just ask about the ambulance nurse? Is the gold standard supposed to be
be that this will be a second person to the numbers that you have, or is it supposed to be like a majors area? That's because I just think from a stress point of view on that one person doing logistically, like in our majors area, there's only 3 nurses, and if you take one of them, that's a huge pressure on them to be doing all the ambulance, but also a huge pressure then on the other 2 left looking after the other patients. Whereas within our department, it's all 3 will take ambulances once they're trained to do it. So they're switching, so coming together.
Okay. Yeah.
Yeah. Fiona, you,
Yeah.
did you hear the question?
Yes, I did. The staffing in all departments is ridiculous. It's probably the best way to put it. So, like some departments, like the smaller departments, it's invariably the nurse in charge that actually takes the ambulances, and then she'll take the I-MIST part, and she may take the AMBO part as well, and direct the person to the area where the patient's going to be offloaded, and then the other nurse will take over. I don't think there's any department in the country that would have sufficient staff to have somebody dedicated to the ambulances. Plus, ambulances, they're not there all the time. They're like buses. Sometimes they'll come and brief, and then you'll have a break. Now, so it's just that the whole point of the ambulance nurse is that the crews know who to go to. So there's not 5 people walking past and saying, just ignoring them, because that does happen. So it's that you have the nurse, or maybe 2 nurses. Some sites have 2 triage nurses, and one is allocated primarily to take the ambulances, but can take the waiting room if they haven't got an ambulance, and the same if the person who's working from the waiting room side doesn't have anybody waiting, they'll help out with the ambulances. So this is where the national protocols are great because they get us all singing off the one hymn sheet, but they all need that fine tweaking locally. So you do need to look at the way you allocate your staff to identify, but from when we did the workforce planning piece and all the recent work we've done with looking at staffing in the departments, we know that there isn't any department that can just have somebody who will only look after the ambulances. It's just, you just don't get the staff. And I know the moratorium's been lifted, so it's a case of looking at the way you function as a team and identifying who is the best person to be taking the ambulances. I mean, maybe the person in charge signpost and say, no, go to cubicle 1, that nurse Sam will take, and then the next ambulance is going to cubicle 8, and you say nurse Mary or Michael will take that patient for you.
Thanks, Fiona. I think the important point is that it is a role. It can be it can be part of other people's duties, but what's really clear is that the pre-hospital services delivering the patient need to know in that department who do I go to rather than standing around.
PCO part for the National Ambulance Service, is that a final grant? Is that here to stay?
Is Declan?
Oh no, that's all about to change.
Yeah.
For the clerical staff, you can't see that the quality is like horrendous. You can't see any of the information.
I know that the National Ambulance Service.
Is there anybody here from?
Is Declan here?
But I can answer Anne's question. Right. Up to very recently, we kept the top sheet, and the bottom sheet went back to the crews. The problem is then when they were doing their quality assurance, they couldn't read the duplicate, and it is their fault. The whole thing is that the PCR is their fault. So they have ownership of it. So then they decided that that they were going to keep the top copy and that we would get duplicate. But we have flagged the issues to them that you can't read them, you can't scan them. So
They know that issue already.
Yeah.
So there is, we are supposed to be going electronic PCRs. Down the line, we have had a meeting at national level. There was to decide, to make some decisions, like, where they printed, are they printed the ambulance, are they printed in the ED, all these, because the systems, unfortunately, probably aren't going to integrate initially. So there's probably going to have to be a dedicated spot within the departments, computer that they will print their ambulance handovers from. But that is still to be finalised. But but it is, we will be going electronic. But as you know, not all departments still, maybe 2016, but not every department in the country has an electronic system. Some of them, it's only the patient's register. That is it. Everything else is handwritten. Then there's other sites that are paper-light, that basically the only thing that's written is the nursing note. The medical is all on the computer. So that's the variance that we have. So it's important that, you know, yes, we want to move forward and as quickly as possible, but we have to make sure that everybody is included.
Sorry, just relatively on the same question from a clerical point of view. The ambulance sheet, which is now the CPO, which is the patient care record, it gets scanned electronically in Beaumont, even EPO. The problem is, you said the form belongs to like the shared services, and the original they're going to take the top copy and leave us the carbon. The carbon doesn't scan electronically, so but the problem is they don't need heavy uniform.
We have faith.
The problem is then, like the DFB was in touch with me last week over ambulance sheets, had I got them scanned, and I said no, we don't. So if you were saying like it's their form, but we're scanning them, it's not going to take them.
Okay, there are a couple of months off an EPR where it will be possible within the emergency department to print a copy of the EPR.
Absolutely. And
and has been identified. And has been identified as a risk, and there is.
But it was going to be a trial for a few weeks, we were told, and before we knew it, we were told there was 10,000 orders, 20,000 orders, and they were continuously using them.
I'm hearing you, I wasn't part of that, but it has been identified as a risk, and hopefully it's going to be
Well, I have nothing useful to
the National Ambulance, sorry.
And it is a frustration, there is risk attached to it.
And from the National Ambulance side, the paramedics, the ambulance crew themselves have given feedback to say that they're not even happy with the PCRs that we have at the moment, and they're completely aware of the problems that we're having. So they are trying to review it, but they're waiting to see what happens with the EPCR at the moment. To lean on. Okay.
It's work around the interface between service and all that.
Yeah.
Are we finished your session?
Yep.
Yeah.
Absolutely.
Thank you very much for Leah has just freshly stepped up to this plate, and I think stepped up with tremendous enthusiasm and ability, and thank you very much for that. The main purpose of today, now that we have everybody in the room, I'm happy to keep yakking for a while about the pain and frustration of trying to implement perfection in a very imperfect world, but the I-MIST-AMBO bit is done now, thank you. The aim of today really was to provide those who will be cascading the training with a walkthrough of the thing, to advise of Leah's availability to assist. Obviously, if you see one of us walking along the corridor in our departments, we'll assist in any way we can too, but Leah will be the reference point for people. In terms of going live on Wednesday the 27th, one of the difficulties that we find with the programs in general is these tools are devised, they're tweaked, they're road tested, they're piloted, they're written, they're presented, and then there's real life, and how do we go into that? So really we're just trying to give exemplars of what the model of care would be in best. You know, there's the big stuff, how many emergency departments do we need? Do we need major trauma centres? Then there is the quality stuff, clinical microsystems, quality improvement, all that kind of thing. And then there's these various tools which we often pull from different parts of the world and endorse them, tweak them and roll them out there. But we're not trying to cause unintended consequence where in all those departments where things ain't the way we seem to think they are, it'll never work in our place. You know, we're just trying to show what we think is an exemplar of good practice, and the feedback that I'm hearing today is always very useful to hear.
Happy to knock around about how tough life is and how under-resourced and underappreciated we all are. We know that. We might as well have a love in, and we are the best specialty in the world and all of that. But the session is finished now. If anybody is in a rush to go away anywhere, by all means, thanks very much. Otherwise, we'll chat away.
Can I just ask people to fill out the evaluation form and leave them in the box outside? Is that all right?
And can I just say, there's two different types of packs. There's packs BD, and so there's one per hospital, and then there's a separate pack for the acute medical assessment units and the rotunda, because there's just slightly different information. So
I screwed up again, we weren't finished at all.
no, it's just to make sure that you get the right pack. Otherwise, you might just get confusion back and forth.
Thanks, Jim. Does any of the other contributors want to say anything before we finish? No? No? Okay. And as ever, thanks to Sinead Riley, who probably had another sleepless night last night. Here she is, I can see her through the floor. There's tea and coffee at the end. The toilets are there, the fire escape.